In Module 1, we laid the groundwork. We explored what public health is, its history, its guiding concepts, and the forces that shape it. Now, we turn to a question that's a bit more practical. How do we actually deliver health and healthcare to people, and what does the future of public health look like in a rapidly changing world? We'll compare healthcare systems in different countries, look at the challenges of quality and access, and see how social forces like racism, poverty, and privilege play out in real healthcare delivery. Then we'll widen the lens to explore population health trends, globalization's impact, and the challenges we'll face moving forward. 2. Healthcare systems and delivery in Nigeria, the US, and globally. Healthcare systems vary enormously around the world, shaped by history, culture, economics, and politics. Nigeria's healthcare system. Nigeria's healthcare system operates through a three-tier structure. Primary care, local clinics and health posts, the first point of contact. Secondary care, general hospitals providing more specialized services. Tertiary care, teaching hospitals and specialized centers. Challenges include limited funding, health spending per capita is relatively low. Unequal distribution of facilities, urban versus rural gaps. Shortages of trained health workers. Infrastructure constraints like unreliable electricity and water. Strengths include a strong network of community health extension workers. Increasing investment in immunization programs. Growing public-private partnerships. United States. The U.S. healthcare system is complex and fragmented. No universal coverage, though programs like Medicare for seniors and Medicaid for low-income individuals cover millions. Heavy reliance on private insurance, often tied to employment. High spending, the U.S. spends more per capita on healthcare than any other country. Outcomes are mixed, excellent high-end medical technology, but also significant disparities in access and health outcomes. Global models. Broadly speaking, healthcare systems fall into a few models. Beveridge model, funded and provided by the government, e.g., UK's NHS. Bismarck model, insurance-based, usually non-profit insurers, with government regulation, e.g., Germany, Japan. National health insurance model, single-payer system where the government pays for services, but care is provided by both public and private sectors, e.g., Canada. Out-of-pocket model, individuals pay directly for services, common in low-income countries. 3. Approaches to healthcare. When designing healthcare systems, countries balance three main priorities. Access, can everyone get the care they need? Quality, is that care effective and safe? Cost, can the system be sustained financially? Different approaches include preventive care focus, spending more on prevention to reduce expensive treatment costs later. Community-based care, delivering services where people live, rather than only in large hospitals. Telemedicine, increasingly important in remote or underserved areas. 4. Quality and coverage. Quality means more than just curing illness, it includes patient safety, avoiding harm. Effectiveness, evidence-based care. Timeliness, reducing delays. Equity, care that doesn't vary in quality based on personal characteristics. Coverage refers to the proportion of people who have access to essential health services without financial hardship, the essence of universal health coverage, UHC. 5. Implementation challenges, cost, workforce, and beyond. Even the best designed health policy can fail if it's not implemented effectively. Common obstacles include cost, funding shortages, especially in low and middle-income countries. Workforce, shortages of doctors, nurses, and allied health professionals. Infrastructure, poor roads, unreliable electricity, lack of equipment. Policy consistency, political instability can disrupt health programs. 6. Regulatory systems. Healthcare is highly regulated, and for good reason. Regulation covers licensing of professionals, quality standards for facilities, approval and monitoring of medicines, pricing and insurance rules, public health laws, such as vaccination mandates. The right balance is crucial. Too little regulation can lead to unsafe practices, but too much can stifle innovation and access. 7. Novel approaches to bridge healthcare and communities. Public health increasingly recognizes that the best solutions often start at the community level. Examples include community health workers, trusted locals who connect residents to services. Mobile clinics, bringing care to underserved areas. Integrating social services with healthcare, addressing housing, food security, and education as part of healthcare. Digital health platforms, using apps and SMS messaging for patient follow-up, reminders, and health education. 8. Social class, racism, discrimination, and privilege in healthcare delivery. Healthcare delivery doesn't happen in a vacuum, it's shaped by deep social structures. Research shows lower-income individuals often face more barriers to care, from cost to transportation. Racial and ethnic minorities frequently experience both implicit bias and structural disadvantages in health systems. Privilege, having social and economic advantages, often means better health outcomes, not because of biology, but because of differences in opportunity. Addressing these disparities requires cultural competence training for healthcare workers, policies to ensure equitable resource allocation, community involvement in designing health services. 9. Population health, past, present, and future. Population health looks at the big picture, the health outcomes of groups of people and the distribution of those outcomes. Trends in morbidity and mortality. Past, infectious diseases like smallpox, polio, and cholera dominated. Present, non-communicable diseases, heart disease, cancer, diabetes, are now the leading causes of death in most countries. Future, we face a double burden. In many low- and middle-income countries, infectious diseases still present while chronic diseases are on the rise. 10. History of public health and globalization's impact. Globalization affects public health in complex ways. Positive, sharing of medical knowledge, international cooperation, faster development of vaccines. Negative, rapid spread of infectious diseases, lifestyle changes leading to chronic diseases, and environmental challenges. 11. Pragmatic challenges. Future public health will need to navigate climate change, urbanization and megacities, migration and refugee health, emerging infectious diseases, political polarization affecting health policy. 12. Interprofessional teamwork. No single profession can handle public health challenges alone. Teams might include doctors, nurses, and pharmacists, epidemiologists and biostatisticians, environmental health specialists, social workers and community organizers, policy analysts and legal experts. 13. Diversity, equity, and inclusion, DEI. DEI isn't just a buzzword, it's central to effective public health. A diverse workforce brings different perspectives on problems, better understanding of varied communities, increased trust between providers and patients. Equity ensures everyone gets what they need to be healthy, even if that means different groups receive different kinds of support. 14. Conclusion, the road ahead. Public health is a dynamic, ever-evolving field. From ancient aqueducts to AI-driven health monitoring, from smallpox eradication to COVID-19 containment, we've seen that progress is possible but never automatic. The future of public health will demand scientific innovation, political will, social solidarity. If Module 1 gave us the why and the what of public health, Module 2 has given us the how, the systems, challenges, and strategies we need to turn ideas into reality.